For those of you online, you are definitely in the majority. We have over 70 registrants that are watching this online. And I think we have 1, 2, 3, 4, 5, 6, which was what we were expecting, bankers here locally. It seems like every year the number remote was going up and the number local in person was going down. So it's a sign of the times, and we adapt. So next year it'll all be remote. And of course, this is also being recorded. Do some introductions. As you know, Melissa and I have done several of these together. And so I'm Jay Kempton. I'm President and CEO of the Kempton Group, and also the plan administrator for Advantage Health Plans, your health plan. Melissa Nance is our Chief Brand Officer here at Kempton, and Melissa is really in charge of that customer, the all-important customer experience. Keeping customers happy and getting more customers is her area of expertise. She's doing a great job. And we'll be sharing the presentation with a few other speakers. We have 2 guests in. I think we talked last year that the Advantage Health Plans Trust Board of Trustees was making a change to the actuary vendor that we had engaged, the consulting actuary for Advantage Health Plans. That change did go into effect, and we actually have the team representing the Advantage Health Plans from an actuary and an underwriting standpoint. We have Vicki Schmeltzer from Strategic Underwriting Solutions is here. We also have Paul Fasili with Windsor Strategy Partners, and they have a few slides. They're actually going to step you all through something new this year. They're actually going to step you through the renewal presentation that was actually presented, the exact presentation that was presented to the Board of Trustees for the rate adjustment this year. So you all will definitely have, we'll talk about full transparency. It will be full transparency during the presentation. Last but not least, we have Corey Zavada, the Trust Counsel that has been working with Advantage Health Plans now, I think it's been 4 years now. So Corey will be remoting in from her secluded cabin in the woods and somewhere in Wisconsin. Yeah, somewhere in Wisconsin. So we're looking forward to Corey. Agenda, real quick. We're going to go through our successes and celebrations. We have quite a bit of performance and reporting, which I'm going to go through pretty quickly, simply because there's a lot of it, and it's all in your packet that those in attendance here have with them right now, and the other registrants, it was emailed to you also. I'm not going to belabor the reporting. We'll hopefully have some extra time to talk about the renewal and some of the other positive changes that we've seen. There'll also be some changes regarding the benefits, nothing negative, all positive and compliance related. The feds keep kind of changing things, and so we have to fall in compliance with that. Then Corey will have a Trust Counsel update for some of the compliance items and issues that we're all going to be dealing with on the health coverage landscape. And then account management and education, and then our open enrollment timeline, and we'll close out. As you all know, Advantage Health Plans Trust is not an insurance company. It is a partially self-insured plan. It is owned by you, by the bankers. Your contributions are held in trust for the exclusive benefit of you and your plan participants. The trust is governed by a board of 7 elected trustees. They're there on the slide. And then we also have 2 advisory trustees. The trustees serve no more than 2 consecutive 3-year terms. And then ballots go out, and you get to vote on them. Celebrations and success. Melissa?
I always have a requirement that if I'm going to present every year, I only get to present good news and successes and celebrations. So we've kept our deal for a couple years. So So couple of successes and celebrations. I usually like to do a quick report on the additional providers that we've been able to add to our contracts throughout the prior year. So when you all get the slides as well as the printed booklet or the booklet handout that you will get after this presentation, you'll be able to see the actual providers. But just in summary format, we've been pretty busy in the contracting and provider relations department, adding 17 new providers to our KPP free program, which we'll talk a little bit more about through the end of the presentation. But just as a recap, those KPP free providers are the providers that are offering the health plan bundled, upfront, transparent pricing. And in exchange for that, we have an enhanced benefit that's available to the plan members on Advantage Health plans. Those providers have been in a variety of different locations across Texas, Oklahoma, even some Alabama, Colorado, Florida, and some of those may not be as relevant for some of the banks that are participating in Advantage Health plans, but certainly for our kids that are off at college or other locations, particularly some of the plans that are covering directors, we are capturing some of that activity. So that's good. We also added an additional 3 direct primary care providers under our KDAP program. KDAP, of course, standing for the Kempton Direct Access Providers. And so that was a benefit that we added to the plan about a year ago, maybe a little over a year ago, that provides a subsidy through the health plan for any of the participants that enroll in direct primary care with one of the providers that are contracted through that program. So that continues to grow. A year ago, we started with 1 provider that has continued to grow, and now we have over a handful of those and have added 3 additional in the last year as well. And then finally, our RBP direct contract providers, RBP, of course, standing for reference-based pricing. And so for a lot of our plans and any of the banks that have chosen to offer one of the choice plans that abandons and replaces a PPO network, we are always looking for opportunities to provide redirection to providers that are reasonably fairly priced. And the choice plans are a really good way to control costs through a different pricing mechanism that does not include a network. But sometimes there is a need or a desire to have a little bit more comfort in providers out there in the marketplace accepting those plans without potentially balance billing members. We've had a lot of success in that, but what we've also been doing is going out and working with providers directly to contract with them to ensure their acceptance on a fair and reasonable rate under that reference-based pricing model. So we've added 13 new providers in that category as well. And again, also on those across a couple of different states, a lot of activity happening in Texas. So several of our rural communities where there is a bank that's participating in Advantage Health plans and there's a local hospital that wants to support that effort, we've been able to secure contracts in those local communities to support reference-based pricing. So great news.
Thanks to those local bankers. It's always great when we can collaborate.
Yeah. So last year at this time, I had the privilege of introducing to you another one of the Kempton children. Isabel Kempton Moore joined our team last year as our HR representative, and we introduced her at this meeting about the same time. She has been busy at Kempton as the HR representative. I'll just say that. And I've had the privilege of working her on some pretty important projects over the last year that have really benefited us as an organization. This year, I have a similar privilege of introducing another Kempton child that is joining the ranks of the Kempton team, George Kempton. So for those of you that are in the room, George is joining us in the room. If you're joining remotely, hopefully you'll get to meet him and talk with him throughout the next 4 months or so as we close out the end of this year going into our renewal. But George joined our team as the education coordinator, and he has previously done some stints at the Kimpton Company in administrative capacities. He's also done an internship with Kimpton. He completed his internship with me in 2020, which you all remember was the year of COVID. So that was an interesting time for all of us. But he completed his degree at OSU, excuse me, in 2020, and he's majored in marketing and has a minor in philosophy. So his role at the Kimpton Company is as the education coordinator, and we're working very diligently on improving and elevating a lot of the education materials and really trying to bring the message that we've been trying to tell for so many years down to the hands of the users. So whether that is the spouse in some cases, or even children, particularly grown children who are off at college and still making healthcare buying decisions that might not have access to the same information that their parents had at an employee meeting, we're really trying to improve access to that information and make the message as simple as possible, as palatable as possible, but also as effective as possible. So we've got a lot of things that we're excited about. It's a little bit of a passion project for he and I both. And for open enrollment this year, towards the end of the year, you all will see the fruits of that labor in some of the education initiatives that we're able to provide. So we are happy to have George on board, and you all will be interacting with him a little bit more through the end of this year. So welcome.
Okay, so performance and reporting. If anybody has any questions, please jot them down. We'll try to address any questions at the end, but I'm going to try to go quickly through these. A lot of these reports you've already seen, so they've been updated for 2022, but we'll go ahead and get started. Like I just said, it's all in your packet. Medical and prescription drug costs. This is just a trend line from back to 2016 through 2022 to date. One of the things that, as you see, really kind of in 2019 and 2020, you see the prescriptions are becoming a bigger and bigger part of our overall plan expenditure. That was something that was quickly getting out of hand. As you all know, also we've done quite a bit and been pretty aggressive on the prescription side, trying to manage those costs. Those things can get out of hand in a hurry. So far in 2022, you'll see it in another slide. Things are looking pretty good on the prescription side. Also, medical spend is down, which is great news, and we'll hear more about that in the subsequent slides. Melissa talked about KPP free. Y'all are very familiar with that, and y'all can read these statistics. The ones though that I wanted to draw to your attention, and this is again the good news report. These are the savings results. So for participants that had used KPP, some of the results there, and you see the largest single claims that resulted in savings actually for both years. We had to check on this to make sure that this was not a problem with our data or our slide. This exact same amount, 2 years running, 104,804 was saved on a single claim. And these were the same procedure, different patient, same procedure done at Oklahoma Heart, and these were large inpatient cardiac cases. Again, had them back to back both years, but that's a big chunk to save all at once. Last thing I'll talk about on this slide are the cash price agreements, which again we're very, very proud of, because those are the result of us engaging with the bankers, providing you all with essentially comparative pricing that you are then, if the banker chooses to voluntarily engage with their own medical provider, potentially a non-KPP provider, and inviting that medical provider to compete and price match with a KPP. Happened 79 times last year, and so far this year it's happened 61 times. So we're actually on track, hopefully, to have even more cash price agreements. And it's an interesting dynamic when patients are empowered with information and are able to talk price with their medical community, with the medical providers. It's something that's missing. It's a huge gap in America as far as doctors and hospitals for a long, long time have not needed to even be aware of pricing, let alone be willing to compete. And this is actually starting to push back on that. And once a provider has to price match a couple of times, next thing you know, a lot of times our phone rings and they want to become a KPP. So those are really great great developments. KPP free savings and utilization going back to 2012. Again, you can see the dollars saved and the number of KPP. Melissa mentioned redirections, also could be known as navigation, where we're working with a patient and they were going to go where their physician said. We were able to interface with them, provide them with information, and they voluntarily chose to use a more higher value medical provider. We're seeing, in 2021 that happened 6,100 times. So we collectively, the bankers and Kempton, are getting pretty good at this, and it's driving some great results. So these are the not so good news. This is the missed opportunities slide. So we do capture the missed opportunities. These would be situations where we had a participant that utilized a healthcare provider, and that procedure could have been done. It was offered by a KPP, but the KPP was not utilized. Since we know what the KPP is going to charge, whether they do the case or not, because their pricing is upfront and posted and contracted. So when somebody doesn't use the KPP, we know what that costs, and we're simply measuring the delta between those two numbers. So largest missed savings events on a single claim in 2021 was 118,000, and in 2022 the largest missed was 104,000. The 104, I believe, is the same procedure that was done by KPPs. This would have been one that same procedure was not done at a KPP, and so it's just the inverse of the savings number. It was a missed savings. As you can see, we've as we get more procedures available under KPP, when you have more of them available, you have the potential for more missed. So that the number of missed opportunities did grow into 2020. And for those of y'all that have called the Kempton Group offices and talked to a Advantage Health Plans dedicated patient advocate, you'll probably have noticed in 2021 the way that we communicated with the patients changed pretty dramatically. And that was really the brainchild of Melissa, and completely reworked some of the scripting that we use with our patient advocates. Now they go a lot more in depth with essentially a financial analysis of, this is where you're at with your deductible, this is where you're at with your coinsurance, and if you choose this network provider based on our historical data, this is what we think that the plan will spend, this is what we think your out of pocket will be. But if you were to choose one of these Kempton Premier providers or use a cash price agreement, this is the dollars that you could save. That has been tremendously effective, and you can see the reduction in the missed opportunities and also the dollar value of those missed opportunities. Switching gears, now we're talking about reference-based pricing. Those of you that offer a choice plan are very familiar with reference-based pricing, but every single bank participant on Advantage Health Plans, even those that utilize a network, if you were to go out of network while being on a network plan, out of network claims are also repriced or they're priced at a multiple of Medicare. So this can be very relevant even to banks that are not on a choice plan. We talked about this the last couple of years, but these are updated numbers. Since January of 2020 through 6/30 of 2022, we've had roughly 30,000 claims that were repriced at a percentage above Medicare. That represents 3,800 belly buttons that had claims that were repriced by Medicare, so 3,800 participants. Of those 30,000 claims, 46 resulted in a balanced bill. That's 0.15% of the total claims through a reference-based pricing plan design. 41 of those were resolved positively, The ones that the other 5, those ultimately resulted in the patient having to work out a deal with the medical provider on their own. Provider would not negotiate, most likely did negotiate with the patient. The average percentage above Medicare in which the negotiation was accepted. First we maybe paid them at 130% of Medicare. They said that wasn't enough. We go into negotiation on behalf of the patient. The average settlement value on those 30,000, or excuse me, those 46 balance bills was 163% of Medicare. This is very, very good. It's very good. Most of the network allowables, if you were to index those to Medicare on doctor's office visits, they're going to be anywhere between, depending on the specialty, they could anywhere be from 120% of Medicare to 190% of Medicare. On the facility side, network allowables indexed to Medicare, they can be anywhere from 300 to 600% of Medicare. So this tells me that the balance bills were generally with physicians or specialists as opposed to hospitals. Billed charges for these 30,000 claims were roughly $35 million. The plan allowed, or the amount of the reprice using Medicare reference-based pricing, was 11 million. Plan savings of about 24 million bucks. The participant savings would also be proportional to that. Okay, Melissa talked about direct access providers. These are the current direct access providers. We do have a handful that are kind of in the hopper right now that we're in the process of kind of onboarding. So direct primary care is something that is growing pretty rapidly, especially in the last few months. It seems to really have gotten some increasing tempo. But Mid-Texas Direct Primary Care in Fredericksburg, Primary Health Partners, is probably the largest clinic in Oklahoma. They have like 8 locations now, and they've already announced several others that are going to be opening in the coming months. Reliant Health Partners in Enid, Remedy based out of Tulsa, Direct Primary Care of Oklahoma in Edmond, which is brand new, and then Simple Primary Care Solutions in Edmond as well. I will bring to your attention that Primary Health Partners in Remedy, they are in multiple rural locations in addition to the metropolitan areas, places like Ardmore, McAllister, Chickasha. Really, well, actually, I think they're looking at Elk City, and I think they're looking at some other facilities. Or other areas. So it's certainly not just a metropolitan-based movement. In 2021, just as an aside, I don't know that this is in your packet, but you might want to jot this down. In 2021, we had 161 bankers that were enrolled in the KDAP program. Again, it's voluntary. 2022, so far, we have 185 enrolled. So again, I think as the DPCs start to become more prevalent and also branch out into the more rural areas, we'll see more enrollment in those providers. Visa Health, I hope that most of you all, if not all of you all, don't know much about Visa Health, because again, this is a chronic disease management program and remote second opinion program. These are for the folks, our fellow bankers, that do need probably the most help with catastrophic or chronic illnesses. We started this program on a limited basis in 2021. In 2022, it was kind of kicked open, wide open, but this is definitely a voluntary outreach type of program. When a claimant is kind of recognized as in need, they have some catastrophic claims, a real walk that they're getting ready to go through. They will be referred by our team to the Visa Health team, which then the Visa Health nurses will then reach out to the bankers. Again, it's a voluntary program. It is all there to help with coaching, understanding your disease state, and then also many times a remote second opinion with a nationally renowned medical provider in that particular field, something that is part of this program. In 2022, we've had 3 remote second opinions that were completed, 1 possible coming remote second opinion, 3 nurse support interactions, but we reached out to a total of 318 bankers that were identified with a need. So out of 318, we only had 11 respondents. So as you can probably imagine, from an education and outreach perspective to the banks, especially HR in the future, we are going to try to close that gap. I think that there are certainly some hurdles that we've got to get over. One of them is the fact that under the current structure of Advantage Health Plans, member banks are not able to have access to protected health information. Sometimes if a nurse needs to get a hold of an employee of the bank, and we want to reach out to HR and say, well, hey, Laurie, can you help us get in touch with Helen? Well, what is this regarding? Well, Visa Health, boom, we already know that, okay, well, Helen must have a chronic condition. And so we're not able to engage HR at this point. We're working to resolve that, though, because we do think that engaging HR at the bank to help us make these connections is going to be good for the employees, good for the bankers, and also good for the health plan. Total savings so far in 2021 has been $127,000, and that's hard dollar savings of about 10 grand, risk negation of $116,000. This is just kind of interesting information. Top 5 high dollar claims in 2022. I think we had this slide last year. It's been updated. Unfortunately, we had one dramatic outlier claim. I don't know if you all can read that. I can barely read it, but the bill charges on that one claimant number 1 was $3.9 million. The PPO allowable, which was on a PPO plan, was $2.9 million. We rejected that PPO allowable. We didn't have a legal basis to reject it. We just rejected it because it just felt like it needed to be rejected and it needed to be negotiated. So we did attempt direct negotiation with the hospital. And as a result of our efforts, we were able to get that claim down. The hospital accepted $1.9 million. The reference-based pricing allowable on that, if this was not a network claim, would have been $987,000. As you all know, these Advantage Health Plans is partially self-insured. We do buy reinsurance to protect your trust fund, and the deductible on that reinsurance policy is $275,000. That means that the trust fund is on the hook for the first $275,000. Anything above that in a calendar year is the responsibility of the stop loss carrier. So you might think, well, why are we jumping through hoops to save a stop loss carrier money? Because we want to avoid the big rate increase. Just like you all, we try to manage not only the trust fund's money, but we also try to do the best we can to make the stop loss carrier, give them some relief if possible, because if we get a big pop, it gets passed on to the bankers. So, and the other ones are just pale in comparison, but you've got those in your packet. I'm hoping that this is the last year that we even have COVID slides. We feel like this should be a wrap-up slide. We don't have to talk about it anymore. Ultimately, the total treatment costs, including testing and treatment, total cost, our estimation was about $5 million. We had 203 bank locations that had a COVID diagnosis within the bank. This $5 million, these were dollars that were unanticipated. As you all know, we had a mid-year increase in 2021. We talked about, we even had a webinar about it. When you have a $5 million worth of losses that were not forecast, that does tend to upset the budget a little bit. Hopefully we're through that. This is seeing it on a graphical representation. You can see we really had 2 large waves of COVID, starting there in early 2020, carrying on till really about the fall of 2021, and things subsided. And then, the one that really freaked us out, that we really thought we were on the downhill slide, felt like we were getting things behind us, was that January of 2022, really December of 21, right around renewal time. Again, it freaked us out because you start seeing these spikes. You don't know, are you at the beginning of these and they're going to keep on going, or is this just a bolt out of the blue? And is it going to subside? Again, we feel like we're in a good place now. Total planned payments, you can see the dark blue line is 2022, much better than the previous 3 years. RX performance, prescription performance. We moved to Southern Scripts, and I have to apologize now. This prescription management is like a chicken soup. It's like word salad of script this, script that. We do have 3 vendors that we rely on to help us with managing the prescription costs. We are hopefully going to get to a point where we will be eliminating 1 or 2 of those to make things much, much simpler in 2023. But so far, Southern Scripts, which is our pharmacy benefit manager, in 2022, they are estimating that their programs have saved the trust about $330,000. The big pieces of their savings is the variable copay program, where we're maximizing the available manufacturer's copay assistance through the utilization of the mail order pharmacy of CRX. Clinical management savings of about $138,000. That's simply making sure that the bankers and Kempton, we're on the plan too, and we've had a little of this as well, making sure that a drug clinician is reviewing the prescriptions, making sure it's the right prescription at the right time for the right patient. About $138,000 worth of savings there. Utilizing the First Choice Pharmacy Network, which is essentially eliminating Walgreens, which we did that early on. Has saved the plan about $60,000 so far in 2022. Our generic fill rate is about 88%, which is pretty good. It could be a little better, but I don't have a problem with 88%. The First Choice fill rate is 98%. As you can see, we have Gary Plunkett here, the CFO, and also the kind of the treasurer for Advantage Health Plans. He is very happy with this graph. This is actually one of Gary's charts, and it is definitely moving in the right direction. That chart was moving up at about the same rate 2 years ago. Scripta, because this is your plan, we talk very openly and frank. Scripta is one that we're looking at very closely on whether to continue or not. They don't know that necessarily, but those are things that we're seriously looking at. We kind of feel like possibly that the savings from the Scripta and their purple dot savings reports may have run its course. We're looking at some additional reporting though, but their numbers in Q1 of 2020, total for 2022, they have identified that bankers have switched drugs based on their recommendations about 612 times. Resulting savings to the health plan of $171,000 and savings to the member in the form of copays, et cetera, is about $21,000. We got to pay Scripta for their efforts. So the net, we are still seeing, according to their numbers, an ROI of about 5.6 to 1. Scripta is one of those, though, again, just very frankly, we asked them about this early on in our engagement. If you all succeed in getting bankers to switch to the right drug, are you going to just kind of basically work yourselves out of a job? And as I said, of course not. Of course not. The things are changing so dramatically. We'll always be able to bring value. That's something that Melissa and I are looking pretty closely at, just between us chickens. Okay, script sourcing. This is the newest vendor that we brought in. Again, just between us and this member group meeting, we are looking very seriously at. We have not seen a proposal. No decisions have been made. A proposal has not been presented to your board yet. But we love that we've saved well in excess of $1.5 million so far on the prescription drug side through internet IPP. Net savings. IPP is International Pharmacy Program. So we've saved about $400,000 in sourcing drugs via International Pharmacy. We've also saved about $1.3 million by getting some of our bankers that qualify enrolled in the manufacturer-sponsored assistance programs. That's a lot of savings, but we do know that there's been, the juice is still worth the squeeze, but there's some squeeze. Some of these programs have been a little clunkier than we would have liked. We are in the process of evaluating that a new program that Southern Scripts, which is our pharmacy benefit manager, they're actually looking to potentially bring the services of script sourcing in-house. What that means to you all as bankers is there would no longer be a third party that we have to interact with for the international sourcing program or the manufacturer's assistance program. That would be all done through through Southern Scripts, which is they're already familiar with all of our drugs. It should be able to provide a much better user experience while also maintaining the savings. Okay, that was fast, but I wanted to save enough time where if we were going to go long, we wanted to go long with the actuary and our underwriter. They are here. We've never had the trust actuary actually present at a renewal meeting, but we felt very strongly that you all need to hear it as opposed to hearing it from the Kempton team. You need to hear it from the folks that are actually doing the work, that are looking at the numbers and are trying to project out what are the needs of your health plan to get us 12 months down the road without any scary surprises. I'm not going to go into all of the reasons why we switched. I think I talked a little bit about that last year, but suffice it to say there were enough surprises that our old actuary did not anticipate that they ended up getting to do something else. One of them was they were insistent that COVID was not going to be a big deal in Oklahoma and Texas because it was not a big deal in other large areas of the country. And I liken that to, running your car off of a cliff because you're following your GPS as opposed to looking out the windshield. So with that being said, I'm going to introduce the SUS and the Windsor team. There are two. They do work very closely together. They're going to introduce what they both do, and they're also going to walk you through the analysis that was presented to the trustees, and they're also going to present the renewal here. So with that being said, Vicki and Paul, are y'all ready?
Oh. Good afternoon. I'm Paul Felici, and I am the actuary on this plan, brand new actuary. Just a little introduction, just a little background. I'm a proud alumni of Temple University. I am the president of Windsor Strategy Partners. And just to let you know that MEWAs seem to be one of our specialties. We're actually the chief actuaries on 8 different MEWAs out there. And me personally, I've been doing this business since 2005. That kind of means I'm old. I just want to assure you guys, you are getting a nerdy actuary. Today, for me, it's day 22,411. Yes, I count every day. I like to think a lot of actuaries count how many days old they are. And just to complete my dating profile, I like basketball, red wine, and horse racing. So, so with that, what do I do as the chief actuary on this plan? My major duties are that I do the quarterly IBNR and give that to Gary and present that to the board. And I take that to be pretty important. I'm the one who tells Gary every quarter how much money do we have to set aside for claims that have already happened but haven't been paid yet. We also do the state attestations, filings. The state always wants to know, is there enough premium to cover the claims? And we're the people to take a look at it, look at the data, and we make that attestation, then sign our names to that. We also do plan design changes that when Jay and Gary have bright ideas that, boy, would like to change the plan to deductible of this, co-insurance of that, we're the people that project how much that is worth. I saved the best for last. The most fun I have is being actuary on the plan, and the duty I take the most serious is that I'm the guy who figures out how much of a rate increase do we need for next year's plan. And I kind of liken it to Nostradamus. So Nostradamus would go into a trance and he would get these visions as to what the numbers would be. Me, I'm an actuary, a little bit more boring. I actually pile through a whole bunch of numbers and make projections of what I think they're going to be the next year. So I'm actually going to kind of walk you through the process of how I come up with the renewal increase. And I take your business and I put all of the money that we spend into 3 different buckets. First bucket is the biggest one. That's what we pay for medical and RX claims out there. And that's nearly 77% of all of our expenses. Then I take a look at the administration, and the administration is TPA services for claims adjudication. It's also for PPO networks, actuaries. We're not a very big part of the pie, by the way. The underwriters, claims management, utilization review, legal, everything that we spend on the plan is counted as administration. And as I said, we have 8 MEWAs out there. I want you to know that of all the MEWAs we have, you're the second best when it comes to administration expenses, as being the lowest, and very, very close to number 1. And Jay, I think the only reason you're not number 1 is that the other plan has a lot lower deductibles, so they have more premium in order to spread their fixed cost on. But you're doing excellent when it comes to administration. And then stop loss is the third bucket, as Jay mentioned. We have a $275,000 policy. So if something catastrophic was to happen, we have somebody who's going to pick up those claims. And that's about 3% of the pile. I take each of these buckets and I project what I think the expenses are going to be next year. And something I want to bring up, because it is a topic all over the country, is post-COVID, I see medical trend as being alive and well. I think that we were a little bit in a lull of medical expenses the last couple of years because there weren't a lot of people that were going to the emergency room. People were canceling services, anything elective people didn't want to do. They didn't want to go in the hospital and get COVID. So there was naturally a gain because of that. But I think post-COVID, again, trend is alive and well. I think we all saw yesterday the report on the inflation report being 8.3%. That's real. That's general inflation. 8 of the last 9 years, medical inflation has actually been higher than the general inflation out there. So it's just a matter of time before this catches up. One interesting thing with the report yesterday about the 8.3%, we've all seen, not that it's gone down a lot, but energy costs, gas has gone down. The component that takes out energy expenses actually went up inflation. So we're actually paying more on a day-to-day basis. I think it went up to 6.3%. And I think that's what really spooked the market out there. So besides the general economy being on fire, I think as we go forward in 2023, we're also going to see a lot more long COVID claims. So COVID is one thing. I think it is in the rearview mirror. But what we're finding is that people that had COVID, there's lingering experiences that people have fatigue, they're coughing, still losing taste. And these people, I think, will be going into the hospital, going to see their doctors, and those are going to be extra expenses in the coming year that weren't anticipated in the past. I think also because of delayed treatment, there were a lot of people that canceled their cancer screenings, that they stopped their radiation treatments, so on and so forth. Well, needless to say, the further advanced you are on the cancer scale, the more expensive it is to treat those people. And I think that that's going to linger into 2023. Specialty drugs, Jay, you guys have done a great job with that. But the facts of life are the pharmacies, they're pretty crafty people. I'm still anticipating close to double-digit inflation. That's just not on your plan. That's on all plans. I'm hoping we do beat that. But as an actuary, it's more prudent to err on the side of caution with that. And then the new one is cell and gene therapy. This is the one that gets me excited. There's actually 3 of them out there, with the beta thalassemia getting approved just 2 weeks ago.
You practiced saying that for weeks. Beta thalassemia.
Beta thalassemia. I could say it. I could say it a bunch of times if I have to. That treatment costs $2.8 million. Plus an additional $600,000 to do the bone marrow transplant, administration, stay in the hospital for 6 months. One thing that happened with COVID is the FDA stopped visiting the manufacturers of these cell and gene therapies. And now that COVID is gone, the FDA is in overdrive to get these approved. So we've seen 3 of them approved already. I think there's going to be another one in the next couple of weeks. There may be 3 more in the first quarter. And as I told Vicki before, these are going like popcorn. This is going to be the new wave of treatments out there. All of them are over $1 million. I tell you, as an actuary, I'm scared to death. But as a human, I'm pretty happy. It might save my life one day. So anyways, it's not as bad as it seems. So I trend all of the medical and RX claims up, but then I also add a margin to the estimate that I have. And part of that is to build up our reserves in surplus. It's also to cover unforeseen events. Like 3 years ago, could anybody have known that COVID was going to be out there and we were going to have a bunch of COVID claims? It's also for adverse deviation. I had information through 8 months. What if the information in month 9, 10, and 11 are a little bit different? I want to be able to hedge my bet a little bit. And then my parameter risk is, what if I'm missing my trend, that I'm actually low on trend? So I add a margin, and that's not just on your plan. That's all of the plans that I work with. I add a margin. So with that, I'm going to give you a simplified example of how I've come up with your rate increase, kind of walk you through the making of the sausage. And I looked at your plan, and over the rolling 12 months from August of 21 to July of 22, if I looked at all of your employees, the average contribution was $1,077. Sorry, Gary, I didn't use pennies on this, but this is pretty close, just to keep it a little bit clean. And then I look at those expenses, all of those buckets that I just talked about. Your medical is about $625 per employee per month. The RX, $188. We do get rebates back on that, so we get to get back $50 on that. Admin is about $202, and the stop loss is about $29 PEPM. Then I go into the middle, and the projected increase is what I'm trending those forward. So for the medical expenses, I'm trending forward at 7.5%. In the RX, I'm trending at 9.5%. And then with that, I'm putting an explicit margin of 3% on top of that. The admin expenses, I think, will be a little bit lower trending, that I'm trending them at 6%. And the stop loss I put as a placeholder is 10%. If you can do better, it's good, but the model really isn't that sensitive because the stop loss is only 2.9% of the expenses. So taking those numbers, I go over to the far right, I project what the numbers would be, and then I back into what the contributions that are necessary to cover all of those expenses. So looking forward to the 23 year, I think we need contributions of $1,147 per employee per month. I know that now they're at $1,077, and with that, I back into our projected renewal rate increase is 6.55%. So there you go. No drum roll, Jay, but I'm introducing our renewal increase at 6.5. And Jay, you said it was very unusual for the actuaries to actually come and make that presentation. Well, I'm going to put a disclaimer on that. You're the best of all 8 of the MEWAs that I have. So when the answer is that you're getting your renewal rate increase of 6.55%, yeah, I'll come and join you. I'll wave. I'll have dinner with you. I have some other MEWAs that they're not going to want to see me this year, unfortunately. So overall, I come up with the rate increase on a macro basis. And then what's going to happen, and I'm going to turn the microphone over to you, Vicki, and then you can go over the mic. But I do want to make just a couple notes before I give you the microphone. And that is that, again, one of my duties as the actuary is that I've been looking at the choice plans that we have out there. I'm looking at all of your benefit plans. And I know that there was a previous actuary that had priced them. In my opinion, the choice plans, I think they gave too much credit for. I believe they gave 26% credit in Oklahoma for the choice plans. I'm looking at it. My models are coming up with a slightly lower number. Early indications of looking at the experience, it looks like that experience is worse, which would kind of tell me there's a premium shortfall in there. And as a result, when Vicki is going to look at the rate increases on a bank by bank basis, the choice plans are going to get slightly more in order to cover that. So overall, increase is still going to be 6.55%. It's just that the choice plans are going to have to go up a little bit to make up that difference. And then one more piece of that is dental. Here's the good news. It's so small. It's only 3.5% of our total that we were able to put in a little bit of a fudge factor in the medical claims, and there'll be no increase this year for the dental plan. So again, slight differentiation for the choice, but not for the dental. That will be flat. So with that, overall, good news, 6.55%. What do we do with that? Well, that's when I hand it over to Vicki.
Well, hello, everyone. Thanks for having me here as well as your underwriter. Exciting to be here. The Kenton Group has done a fabulous job, in the administration and controlling costs of your claims. They added up, and I was looking at the numbers between the medical, the RX savings. Those are huge numbers. Imagine if that was actually cash out the door. Those savings numbers, it looks like a lot of numbers, but imagine if that's your checkbook and it's leaving, which it is your checkbook, it's your health plan. So that's the cool thing. Another reason I'm so excited to be here is I get to share good news with you, but I, in my early career, was a community banker. In my college years, I reported to the president, I prepared for the board meetings, I managed Fed funds, sweep accounts, the large employer accounts, so it's kind of fun to get to work on your health plan as well. I've been in the business 30 years, worked over 15 years with Paul on trust MIWA business and pricing the risk. And our job is to take that macro level. Paul's looking out the rearview mirror, I always say, what happened with the plan, and we're projecting and looking forward, saying we are the medical experts. We have RNs, ICU trauma nurses. We have a lot of folks in our team. You have a team of working for you, a team of 12 underwriters looking at all the detail, ICD-10, CPT codes, RX, and treatment on a per group basis. We look at that 6.55% that Paul just talked about, and we classify them into contribution risk categories. And those contribution risk categories are listed here. So a group is placed into, a bank is placed into preferred, standard, substandard, or high risk. And then we also, as Paul shared, we looked at, is it choice or a non-choice benefit design? Because there is some pricing differential required this year. So take it from there. And so what the goal of the renewal process always, and this is, we call it block management, and it's your trust management. It's really managing to make sure that, yes, we need 6.55% overall for the bank, but we need for the trust, but we need each bank and cohort paying the appropriate amount. You all subsidize each other. It is your health plan, so you are like a mini insurance company, and it's making sure that each one pays their own. And then that we want to retain, all of the best business and keep everything together that we can in the trust. We want to keep it growing, frankly. So in the process, we await Paul's wisdom as he looks forward into his crystal ball. We need 6.55, and he showed you the calculation. I was pretty impressed. You could understand that, right? And sometimes the actuaries, you can't. And at the same time, though, we have a team of underwriters that are very granular view, looking at every member's claims and seeing what was happening. And that savings is huge, seeing how much is going into the plan. So the block increase is determined. We look at the highest range and then the lowest range. So that 6.55, we look at mathematically, what can the goalpost be for the best rate increase, and then the higher that we need on some of that more substandard high risk business. And then every group is placed into a category, a contribution category. So looking at that, we apply risk factors. That's what an underwriter does. And then we put it into a risk category. And as you can see here, we have the preferred. Then we have preferred choice if they're on a choice design. We have standard, substandard, and high risk. And I must say, it is quite impressive that so many of the groups are running quite well. You're running very well as compared to, as Paul said, our other trusts. So, hats off to all of you and your health plan and making great decisions, seeing the Kempton suggested providers. That's all wonderful because that's what drives you into those lower risk categories. So that's cool. And those are recognized with the lower contribution increase categories. So they range from 2.3% on up to the average premium increase of 6.55%. So you might be thinking, where am I falling? That's all to come. That'll all be released and so forth as we're digging into additional updated data, increased data, because there's always, right? We are the most complex thing to price, the living human body, that unfortunately we never get older. We always age, and there's always something going on with every one of us. So we watch, and so we make sure we get this as tight as possible right up to the very end of the renewal. So some, fast facts about your block. The trust, the weighted average then, as we said, was only 6.55%, which is a very good renewal. Looking at, you just heard what the, consumer price index is at, inflation. Generally, the healthcare side runs about 4% higher than the consumer price index in our experience, in our trends. So looking at that, I did some additional research just to show you kind of factually how good your increase is and how well you've done controlling the healthcare costs of your plan. On the exchange right now, for those in the Oklahoma exchange, meaning ACA, the Affordable Care Act, and those under 50 lives, that average increase anticipated at this time is 6%. They're still filing for what's going to be approved and put through in the increase. So they're at 6%, but your average is 6.55. So imagine there's going to be higher and they're lower. So you're still coming in really great shape. In Texas, it's even better. Texas, some of the larger carriers were ramped as high as 13 to 15% is going to be their higher increase level on the Texas exchange. And of course, the Texas DPI is still looking at approving those increases, but their average even filed right now is at a 9.31. So you're in very good shape as compared to that. And so really, when you think about the members of this trust and mini insurance company, so to speak, if you look at it from that perspective, 86% are receiving 6.3% or lower increase. So, congrats to all of you in controlling the cost of your plan the best that you can, going to the right providers and working with the Kempton Group in doing that. You made some great progress this year, and it's always great when you can build reserves, and that helps prepare for those unknown times as well. So we're happy to be working on the plan. So some of the next steps, and certainly Melissa, Jay, George, all of them are going to share with you the next steps. But here's an example of, because how we price the health plan is just slightly different than what you are used to in the past. We use a bit more granular method of pricing that ensures you stay as competitive as possible to gain new membership, stay within your trust. So this is what your renewal output is going to look like. Your letter that you're going to receive is going to be a little more detailed and be more specific to certain designs. So just an example here, it's going to be very similar to this as we work through all of the details coming up, but you are going to see your rates, your current rates for your design, and then we're also going to give you alternate quotes to 2 lower cost designs. And if you're not on the choice designs today, you'll be receiving an alternate for choice designs as well. So there will be opportunity to stay on the same plan you're on, move to a different design if you so choose. We want the trust to be able to offer as many plans as you could have in the public market, because this is your own trust. And that's what we're looking forward to doing in the next coming weeks. We're going to work diligently with the Kempton Group. So
I think our time is up.
yeah. As we, there we go. So all of that fabulous information. Any questions for us?
I did have a question. You mentioned when you send out the renewal notice, you're going to have other options for lower price plans. Does that affect the planned rate increase in any, since you're shifting, if you're recommending there's a lower?
Very good question. This will remain the overall projected block increase. What when after everyone makes their adjustments and what you're going to move to, we call that the effective rate increase, which is always different and generally lower than the offered increase. And the good thing is that because he's the expert in pricing the base rates and we as underwriters build on top, we make sure that even when you're adjusting, we're obtaining the rate that we need for the designs that you're transitioning to. So we're good there. Good question.
Yeah, AB, if I was just to add one more comment with that, the 6.55 is what me and Vicky call an actuarial rate increase. So you can actually mitigate your rate increase, like Vicky said, with going with a plan with a higher deductible. So you can almost mitigate it to a 0 rate increase. From an actuarial perspective, I see that still as getting the 6.55. Gary would see that my cash rate increase would be less, but overall for the plan, it would be neutral.
Very good question. So again, we're trying to make sure that you have the opportunity, again, as anyone else going through a renewal, but a better opportunity to have a buy down what's appropriate for your particular bank. Anything else today? Not real. Hand it back over to your Kempton experts.
Bankers, you all have been here and listened to us talk before, and you're probably thinking, well, what about the buckets? What about, not being able to move about anything that we know about buckets is gone. So that was a Milliman design. That was a previous actuary. It's from here on out, the idea of where a bank can't move more than, one increase here, or, all those restrictions that we used to have occasionally, those are kind of out the window. As Vicky mentioned, her entire team is an underwriter. So they are actually looking at your specific bank. So if you were wanting to move to a lower cost plan, the rate that you will pay will be something that will have to be determined by Vicky after they take a look at your claims. That's very, very different than we have had in the past. I mean, we used to be able to essentially produce a rate sheet with all, I think there were over 1,000 rates, taking into account all the different plans, all the different options, and all the different buckets. But there was a rate table, and it was always, if depending on where the bank went, was what rate you went into. And that was a very imperfect science. And so we, as in your board, we have an ex-board member here. We used to worry and talk a lot about plans that were subsidizing each other and really just some inconsistencies that were as a result of these static rate tables. Again, now individual banks will be paying really whatever is most accurately determined that they need to pay for their given risk and the plan that they're on. So the number of rates are going to start diverging quite a bit. Now, what does that mean to a bank? Well, that means if, ultimately these rate increase categories, bounce around here a little bit. These rate adjustment categories that Vicky was talking about, the preferred and the preferred choice and all of those, we're not always going to have, preferred may not always be a 2.3. Preferred, if we're having a really great year and we are well reserved to the point where we have maybe excess, the preferred rate may be in some future year, it might be a -3. We may also get to a point where once we get the choice plans priced out more correctly, again, the previous actuary, we think that they were comparing the PPO pricing to the Medicare pricing. And we feel like they got it, and Paul's work is kind of bearing this out. We feel like that they got it mostly right in Texas, but we feel like that they overestimated the differential between the available networks and the Medicare pricing. So the choice plans right now, they have their own risk, their own rate adjustment categories, because those choice designs are going to have to be there in the process of being recalibrated. So we may have a different rate adjustment for the choice plans for a period of a couple, 3 years until they kind of get recalibrated to where they start to be priced correctly for the anticipated claims experience. And then those may end up falling off as rate categories once they get calibrated properly. But as Vicki said, we've got 86% of the banks in the trust will be getting an increase less than the overall increase that the trust requires. Some of the trustee decisions that were made for 2023, which we'll be talking about as we kind of are in the final, we're in the final hour of our presentation, was an update to the underwriting strategy for new and renewal business, which I just talked a little bit about. We're also announcing that the board decided to make the decision to terminate our relationship with Healthcare Blue Book. Healthcare Blue Book they were one of our favorite partners for a lot of years. You all have probably seen they're getting more and more difficult to work with. The timing of getting rewards has drug out considerably, and really just they've gone through 2 or 3 M&As. And as bankers, I'm sure you all know what that, when they say, well, there won't be any changes, we all know better. And so we will be severing that relationship. Melissa's going to go into a little bit more detail on that. We also are pleased to announce that there's some enhancements to the KPP benefits under the high deductible health plan, high deductible health plans. And so we'll talk a little bit about that. Those were something that the trustees approved. And then a couple of housekeeping changes, which we do every year, which we have to update the minimum value plans out-of-pocket maximums because they are indexed to the federal out-of-pocket limits under the Affordable Care Act. So those are really housekeeping we see pretty much every year. Just as a reference, we update this every year. We show it to you every year, the historical rate adjustments going back to 2017. You see we've kind of had some ups and downs there. We are taking into consideration the mid-year in 2021, but over the last 7 years, if you average them out, including the 2 in 2021, roughly 6.4% over 7 years. We wish it was a lot less, but it's also it's something that is we're pretty proud of. It is always compared to what. If we're able to manage the trust at or below medical trend, then we really feel like we've accomplished something. Do we wish medical trend was less? Absolutely, just like you all do. But that's kind of the tail of the tape on that. And as Melissa and I's agreement, the good news goes to Melissa. She's got some other good news to share with y'all.
So this is a summary of the other changes that will occur for the other plans that we have in addition to the medical plan. Also already announced the dental plan. So for those of you that have these additional benefits, we'll provide this information in your renewal letter, but the dental rates are not changing. The vision rates, we actually are still in what's called a rate guarantee. So that means the plan wasn't up for renewal this year anyway. So the rates will continue to stay the same for that plan, and those will be reevaluated for next year. So that'll be a different discussion probably next year. Maybe we'll switch that over to his side for that presentation. And then the last ones that are listed there are the other ancillary benefits with Unum and then also Leaders Life. So if you're a bank that is carrying the Basic Life, which is an employer paid policy, or a voluntary life, which is an opportunity for an employee to add additional coverage to their life insurance portfolio. And then also the long-term disability policy, those two thankfully received a rate pass. So we were not in a rate guarantee, but Unum extended a rate pass for this year. So we'll be in a 2-year rate guarantee on those for the next 2 renewals. And then finally, for those of you that have the Leaders Life product, so those are a little bit more individualized. There are 2 opportunities there to increase your life insurance. There's some really unique combinations of coverage for not only the employees and the spouses, but also children and grandchildren as well. And then there's also an accident policy. Those rates don't change. They're individually underwritten based on demographics, which include age and tobacco usage. And so those rates are not changing as well. So that's the news on the ancillary benefits.
Good.
Okay, so let's talk about just kind of a couple of more detailed pieces of information about some of the changes that are occurring. We mentioned these on the trustee decision slide, but want to make sure that you have the actual corresponding information that goes along with it. So the first two changes that we're going to talk about are the changes that we come to you every year about. And so under two plan designs that we have, the first being the minimum value plan, and then the second being our qualified high deductible health plans. We have to make changes to those plans every year to continue to trail what the requirements are at the federal level. So under our minimum value plans, the maximum out of pocket for both the single and the family is increasing. So in 2022, so currently the way those plans work is it's an $8,700 out of pocket max, which just as a reminder, an out-of-pocket max on a health plan is basically if everything goes wrong that could go wrong, every deductible is owed, every coinsurance cost share is owed, and then also every copay is owed. What is the max that an individual would be out of pocket on that plan design? This year it's $8,700 for an individual and $17,400 for a family, but we have to increase those to continue to follow the regs. And that's going up to $9,100 and $18,200 respectively.
And that's just on the minimum value plans.
And then on the qualified high deductible health plans, as a reminder, those we have two plan designs that qualify as what's called a high deductible health plan, which means that those two plan designs are eligible to be paired with a health savings account or an HSA. In order to have that plan design and in order to get a tax favored benefit for contributing to a health savings account, there are some requirements of those plan designs. One of the requirements is that with the exception of preventive benefits, there can't be any benefits paid under the plan until the deductible is met. And there is a minimum deductible that has to be applied to the plan to be considered a high deductible health plan. So in other words, you can't have a high deductible health plan with a $250 deductible. So each year that gets recalibrated as well. And so we every year at this time have to make that change. So in 2022, the deductible is $2,800 and that's going up to $3,000 in 2023. Okay, and then let's talk a little bit more about the additional benefit that we are changing or improving for 2023 as well. So one of the sort of conflicting or at least complex dynamics about our Kempton Premier Provider or KPP free program has been that for an individual that's enrolled in a high deductible health plan, I just mentioned that we can't increase benefits. We can't improve benefits. We can't waive deductibles because on that plan design, the only benefit that is available before a deductible is met is preventive services. So mammograms and colonoscopies are covered at 100% with no cost sharing, but no additional services, including diagnostic procedures, can be covered before the individual is out of pocket their portion of the deductible, which on the two plan designs that we have is $2,500 or $5,000 respectively. So although there is still a benefit for utilizing a KPP-free provider and getting access to more favorable pricing through the utilization of those providers, it still is a little bit of a disincentive for those individuals to redirect or go, change providers or even travel when they don't get the same benefit of having a lower out of pocket as other individuals do who are enrolled in a more traditional PPO plan design. So that's always been somewhat challenging and complex to talk through. We've developed lots of creative talking points about that to still make sure that we demonstrate the value of those plan designs and utilizing KPP free even when enrolled on a high deductible health plan. But there's been a lot of conversation about that dynamic as redirection and navigation to more reasonably priced providers continues to become more prevalent. And so earlier this year, we had some conversations with legal about what to do about this. And ultimately, where we came to is that there is a minimum requirement. The deductible has to be a minimum deductible to be considered a high deductible health plan, and that's not changeable. But our plan designs both happen to have a deductible that's actually higher than the minimum. So there's a difference there. There's where our plan designs deductibles are, and then there's what it's required to be. So what we decided is that we have the opportunity to lower the deductible a certain amount on KPP-free procedures, even for individuals that are enrolled in that high deductible health plan design, and still have a little bit of a benefit, even more so of a benefit than what you would have had previously. So that is a plan design change, and how that will work is if the deductible is if the deductible is $2,500 on the one plan design, the HDHP 2500, then if there are medical procedures that are being done with a non-KPP, with a non-Kempton Premier provider, then the participant has to pay their deductible up to the $2,500. However, if the participant utilizes a KPP-free provider, then their deductible actually gets lowered, and instead of having to pay the $2,500, they'll only have to pay the $1,500, because $1,500 is the minimum level in 2023 that the plan is required to have to maintain the status to continue to be a qualified high deductible health plan. So there is a savings there on the deductible side. And in addition to that, after the deductible is met, once the deductible is met, then the plan does have a little bit more flexibility in continuing to do things like waive coinsurance. So this is an enhancement. The same enhancement is being made on the family side to true up to also what the requirements are under the regs for family enrollment. And the same change is also being made on the high deductible health plan 5,000. So what that will look like is that's a higher deductible. It's a $5,000 deductible. So for non-KPP services, an individual would have to pay $5,000 of their portion of the cost before any benefit under the plan would kick in. However, if they're utilizing a Kempton Premier provider, then that would lower the deductible on those services down to $1,500, and then coinsurance would kick in and actually be waived in that case after the $1,500 is met. So that's a real enhancement. We're looking at ways to continue to communicate that both in our educational meetings, as well as in the materials, as well as in our call center, to try to continue to get that message out there, and hopefully to improve additional utilization with the KPP-free providers, even for those members that are enrolled in the high deductible health plan. So this is a win for us. We always have a little bit of a challenge around the high deductible health plans and how to continue to provide an incentive for individuals when you don't really have the ability to waive deductibles and coinsurance. And that's always been, it creates a little bit of frustration with the members who are enrolled in those plans, and something that we sort of have to talk them through. You know, we've done some counseling on how to write your congressman for those changes. But we found a creative way around that, and it passes muster with legal. And so we're happy to announce that change for the new year.
Yeah, this is a little wonky, but I mean, as Melissa said, it does provide an incentive now, albeit a little bit smaller, but it does provide some incentive for a participant on an HCHP to utilize the Kempton Premier provider. I have spent a lot of time trying to get to somebody in DC that will listen to this. Again, you know, we've talked about it before. When a participant is looking at having a mammogram, maybe a diagnostic mammogram, that's a relatively small dollar procedure. If they're on a high deductible health plan, you know, they're going to be hopefully prudent, and they're going to choose a high value medical provider because it's going to be able to save them some money because it's lower than their deductible. But when they're looking to have a hip replacement or something that's a large dollar, and they start looking at going to the big hospital, and maybe it's going to be 80 grand over there, or going to a KPP and maybe a hip replacement is 39, to the patient, either place they choose is going to meet their deductible. And so from their perspective, this choice and this choice, their out of pocket will be the same. And so it's really been, the irony is that the consumer-driven high deductible health plans really don't drive consumer behavior except on the small stuff. So hopefully this will be a big step to change that.
Okay, let's talk just a little bit more about Healthcare Blue Book. Jay mentioned some of the administrative challenges that we've had and that have continued to increase over the last couple of years. And we all know that sometimes your members have felt that as we have. But the other thing I just wanted to mention about the termination of Healthcare Blue Book is that a couple of months ago, it's probably actually been 6 months ago or so now, we sent out an update just about how the No Surprises Act and the transparency and coverage requirements were going to also affect some of the benefits on the plan and how we operated as far as balance billing and what additional consumer protections might be out there. But one of the things that also did is open up some requirements for plans to have access to search tools that are provided to individuals to be able to search and look for fairly priced providers and navigate through what the difference in cost are in their communities. Well, that's a lot of what Healthcare Blue Book was providing. But in order to meet some of the requirements under the No Surprises Act, we've had to identify and conduct due diligence on other vendors to be able to meet the full scope of what those requirements are. And in doing that, there were some opportunities for us to improve the functionality that was available to the members by utilizing other vendors than Healthcare Blue Book. There were some places where there was overlap, and there were some places where there was duplications. But ultimately, that's also another factor that came into the decision when determining whether or not to continue with Healthcare Blue Book, is because at some point, there's a lot of resources. There's a lot of tools in our toolbox to be able to help members to search and navigate to fairly priced providers. But if those resources become so plentiful that you're not really sure which ones to use when, then it just doesn't get used at all. And so there are some additional tools. I can tell you that one of the tools that we've already sent out to you and that you've already kind of heard us talking about is a tool that is available with Payer Compass, which as you all might recognize that name, Payer Compass is one of our partners that works with us on repricing claims that are priced through Medicare reference-based pricing. So for those individuals that are enrolled on the choice plan, or if you're not enrolled in a choice plan and you're visiting a provider that doesn't participate in the network. So Payer Compass is a vendor that we've been working with, and they provide lots of support on those reference-based pricing plans, but they too have an opportunity and a tool available to help with some of that search navigation. The other thing that I would just say about Healthcare Blue Book and the termination is that we are a little bit in a unique position at the Kempton Company, which is not the case in every third-party administrator's customer service call center, in that we have some internal tools that we use as well. And so when the members are calling our office and we're talking to them about the cost disclosure and the benefit disclosure, because of the access to the data that we have through the contracts that we negotiate with our KPP-free providers, that gives us a window into some additional information. We use those tools internally as we're doing pricing disclosures to your members when they're calling into the call center. And so utilization with Healthcare Blue Book, candidly, has gone down significantly in the last couple of years as our efforts have ramped up internally in our call center. Just for grins, if this is helpful information to you, we've reported here to you what the amount of the rewards are that, which is probably the component of Healthcare Blue Book that most everybody is aware of. And that is when you go to a provider that is a fair cost provider, then not only are you getting the benefit of paying the lower cost, but you also have a reward that's attached to that, and cash is paid back to the member. We have seen rewards sort of go up and down, but there's an interesting correlation in that the more Kempton Premier providers, the more KPP-free providers that we've added to our arsenal of contracts that are available, the more rewards get paid. And so one of the dynamics that's occurring is that KPP-free utilization continues to increase. That benefit for using a KPP-free provider is that the deductible, the coinsurance, the copay is waived. So the service is covered at 100% for the participant. And then in addition to that, there's a cash reward attached to that. But the member hasn't necessarily done anything behaviorally different as far as searching in Healthcare Blue Book or utilizing that tool to be able to get the access to the reward. What they've done is engage with our team, and we've assisted with that redirection. So we kind of see that fluctuate a little bit. But what we've seen at the very least over the last couple of years is that the majority of the rewards that are being paid for services that are also being done through the KPP free program. So all of those together felt like reasons, and we just wanted to talk with you all about that and sort of go through some of that logic that the trustees also considered in making that decision. But we feel very confident that based on this information that and the replacement for the other services, the other resources that we have available, that this will not leave a hole or a gap in the plan as a result of terming Healthcare Blue Book. Okay. Just a couple of final sort of reminders about the other benefits that continue to be available. KPP free, pun intended, I guess, is always our premier service that we talk about. It's the one that generates the most amount of savings. It's the one that's the reason that we take the most amount of calls in our call center. And it's the one that seems to have the most, positive view from the participants. And so I reported earlier the number of providers that we've increased and added to the program. The number of procedures also continues to grow. So I just wanted to give you some encouragement and put a reminder for you that no matter where you are located, no matter where your participants are located, if you've got employees that are in or out of state, that benefit is available. It's a very important one. We will continue to focus on it. But what we ask from you is that you just remember that it is easy. We like to say around our office, and hope that this is easy to remember for you all and your members, that it's as easy as 1, 2 free. Anytime that a participant needs to have medical services, we just ask that they call us. It doesn't obligate them to anything other than giving us an opportunity to give them information. We will do a price disclosure, and so we'll determine particularly what the procedure is that that individual needs to have, and we'll give them a cost analysis of what the cost of that procedure is expected to be in their geographic area. And then we'll also do a little bit of a disclosure about how the benefit would cover that procedure. And depending on where the individual is at their cycle of their deductible, it could be more or less, but that's an opportunity for us to talk to them about how those benefits would cover those services. And then, of course, we also educate through that process of any alternative options, which would include KPP-free providers, and talk with them about a potential to change course and visit a KPP-free provider. Step 2 in that process is if the participant makes the decision that they do want to redirect and visit a KPP-free provider, they would receive a voucher. That voucher can either be delivered through the portals that we utilize and the email services that we use, or also to their cell phone through the app, which is very user-friendly and easy to use. They'll present that voucher at the provider, and then that service is covered at 100%. I think at this point in our history with KPP free, a lot of people are very familiar with this process, but there always does seem to be one thing that we do need to remind everybody about, and that's the importance of calling us and having that voucher. And the more familiar that everybody gets with utilizing the providers and knowing what providers are out there, what we start to see is that participants start self-directing. And, candidly, I love to see that, right? That means that all the education that we've been doing is working, and there's a lot of access to information out there, and people are starting to learn and integrate these behavioral changes into their own day-to-day lives. And that's what's causing them to reach out and go to providers that they know are KPPs. But it's still very important that we're involved in that process, because that's what helps us ensure that the claims and the payment for those claims happens correctly, and the participants don't end up with an unintended consequence of having a bill that they should know. So that's why we give this reminder every year, is just to make sure that everybody continues to rely on us and let us assist with that entire administrative process, but then also we don't want to miss that opportunity to educate the members in the process.
Yeah, and it can seem a little strange. Oh, why do we have to have a voucher? Don't they recognize Kempton? And that is all true, but it's a little bit more in the weeds. When you go in, McBride is a great example. McBride Orthopedic Hospital is a great KPP, But if you just self-direct or go there without calling us first and getting a voucher, what's the first thing that they ask you for? Insurance card, ID. Well, if you hand them an insurance card, if you look on the back of your insurance card, if you're in Oklahoma, it says, healthcare highways, and file the claim with the PPO. So when that clerk is taking your intake, they are going to set the insurance as healthcare highways. What that means is that the bill goes to the PPO network, gets repriced, comes to us with a healthcare highways price on it, and our system then drives that within our system to pay it at regular benefits, deductible and co-insurance. We have to get the medical providers to change it in their system instead of dropping it down and saying Health Smart or First Health. They've got to drop down and choose Kempton Premier Provider, and then that actually routes the claim in a different direction. So once it hits our system, it's paid at 100%. It also tells the medical provider system that they do not need to collect a patient responsibility. It's a little clunky, but that's the reason the voucher exists. It's like a single-use ID card for just that procedure. We are working, which I think Melissa's going to talk about in the next slide, but the app, we're getting pretty close to a point where the voucher can be electronic through the app, where the medical providers, if they have the capabilities, technically, they'll be able to actually just scan a QR code, a virtual voucher, if you will, that they receive from us, which will drive the claim where it needs to go. Obviously, not all medical providers are going to be set up with that initially, though.
Okay. So we did communicate out a couple of months ago. I think we were looking earlier before the meeting. I think it was in about June that there have been some enhancements to the app. So this is a good time to just remind you that whoever your representative is within your organization that's responsible for receiving the information from the Kempton Company and disseminating that within your own institution, make sure that our email communications are on your safe list, and they get through all your filters because this was an upgrade. There is some additional functionality in the app that the members have access to at their fingertips. And the search term has changed since this upgrade. And so if you're looking for this app on the App Store or in the Google Play Store, you used to search for Coral Healthcare. Now you'll be searching for KPP Free, which obviously is a lot closer to the branding that everybody else is expecting and used to and recognizes. In the interest of time, I think I'll maybe summarize this slide and just remind you that on the on any individuals that are enrolled in a health plan with Advantage Health Plans, except for the high deductible health plans, the benefit of Kempton Direct Access providers is still available. This is an opportunity for the member to enroll in direct primary care with one of the approved providers that we mentioned earlier in the presentation. And for doing so, the plan covers the subsidy or the payment to those Kempton Direct Access providers at 100%. And so any of the services that are covered or that are rendered from those direct primary care providers are also covered through that subsidy that's covered by the plan. And so there are some advantages to enrolling with a direct primary care provider through that program, which, not the least of which is having an additional advocate on the patient's side to be able to assist with wellness and disease management and those types of things, but also to be able to assist the patient with identifying reasonably priced providers, which we also support.
Okay, so before we move on to compliance, we've got a couple questions from our online audience. One of the questions was, why have our high deductible health plan premiums been some of the most expensive premiums historically, when this feels like it goes against the idea of the HDHP benefits?
So just to repeat the question so that everybody online and in the room can hear, the question was, why have the high deductible health plan premiums been some of the most expensive premiums historically, when that seems to go against the benefit design of that plan?
Yeah, I think it's more of an actuarial question, but I'll certainly take a stab at it. The high deductible health plans, when you start talking about what drives claims and drives expenses in advanced health plans, I mean, we're community bankers, right? If you look around, we're not all spring chickens. We are an aging population. And so when we have claims, we tend to really have claims, and I mean large claims that sometimes can carry on for years and years. The difference between a $1,500 and a $3,500 or a $5,000 deductible, when you're talking about a $300,000 claim, it's a rounding error. It's just not that big of a deal. I think when we read about high deductible health plans and how they save tons of money, they are going to be generally in younger, healthier populations where a majority of the claims are within or below that deductible. And in those situations, when people are, the only claims they really have are the small dollar ones, and if it's truly their nickel, then they're going to be a better shopper. So they do result in saving money. But if the claims that you have that your population which is advanced health plans, that is really driving the cost, those are generally much, much larger claims. And the deductible is just not as material when you're talking about bigger claims. I hope that answers it. And if not, maybe Paul and Vicki can do a webinar on that at some point in the future, but because I hope I'm on target somewhat.
Oh, yes.
Okay.
We definitely am.
All right.
See, he's a closet actuary.
Guilty by association, I think.
Okay, and
There's
so,
2 more questions.
Regarding the enhancements for the high deductible health plans, we had a question on, is this only for KPP or is this also going to include for the RBP direct providers that we have?
Oh, great question. So the question was related to the high deductible health plan enhancement. Would that be only for KPP free providers, or would that also include the additional direct contracts that we have, which are based on reference-based pricing? That would only be for the KPP free benefits. So the only enhancement that occurs on any of the plan from a benefit perspective is to waive the deductible, waive the co-insurance, waive the surgical copay when a member visits a KPP free provider. And so we're trying to true up the high deductible health plan to have parity with those same benefits on the non-high deductible health plans. So that would only be for the KPP free providers.
All right, the last one we've got right now regarding the benefits is just a clarification to make sure that they do understand that the rewards will be dissolving with the termination of healthcare Blue Book.
Good question. So to repeat the question, with the termination of Healthcare Blue Book and the rewards program that we talked about, would the rewards program also be going away? And they would. We will be doing, I saw an update today, I think, that we will be processing runout. So that means that any claim with a data service prior to the termination of Healthcare Blue Book, which would be through the end of this year, if it's eligible for a reward, then those still would be paid out, right?
As long as the rewardable, that's a word, or rewardable claim is incurred in 2022, it will be paid even if the reward is ultimately paid sometime in 2023.
Okay, I think that's all the questions from online. Should we pause for a sec to just see if anybody in the room has a question before we go on? I'm getting head shakes. That means no questions. Good. Okay.
So Gary is going to speak just real quickly for those of you all that utilize the Kimpton Group's ACA reporting and pay-for-play information and pay-or-play, essentially the administration of pay-or-play for the Affordable Care Act. Gary is just going to walk us through a slide. As y'all know, the folks that do utilize those services, Gary is kind of in charge of all things pay-or-play. So Gary.
Good. My name is Gary Plunkett. I'm the CFO of the Kimpton Group, and ACA is alive and well, unfortunately. Congress has not chosen to repeal it, and the IRS still wants your money if you're not filing and reporting correctly. So we will be sending out an email in a couple of weeks notifying you of the deadlines that we need if you so need our services to complete that reporting for the ACA reporting. And that's for your 1095Bs, 1095Cs, and the reporting. That's for the 2022 calendar year. What we ask is that please, please, please just give us a response and say yes or no. If you have your own solution, that's great. If you still want our services, just let us know so we can get you on the calendar, get you marked down, so we know who we need to start running reports for towards the end of the year, so we can get those reports back to you for your review so we can meet the reporting deadlines come January 2023. Every year, the IRS has extended those deadlines. Last year, they kind of signaled some intent that they were not going to, and there is a very short timeline to get all the reporting done to your employees and get filed with the IRS come January. So we will try to start as early as possible, but just give us your intent if you want us to help you or not. The rates are the same as last year. Everything's really the same as last year. So it's easy peasy. Just let us know if you want us to help you or not. Any questions? Okay, that's easy.
Thank you, Gary. Okay, we're going to now pull the string between the tin cans really tight and see if we can pipe Corey Zavada in from Wisconsin.
Thank you for having me here today. I'm sorry I can't be there in person. And I feel a little bit bad because there's so much good news shared today, and I get to have a couple slides that are not the best of news from an industry standpoint, not necessarily plan related, but we will get through that as well. Thanks for sharing that, Reagan. I'm going to let you advance my slide. So the first thing I want to talk to you about is a dependent audit that started in 2021 and wrapped up in 2022. As you can probably imagine, it is impermissible to have dependents on your plan that should not legally be on your plan when you butt it up against the eligibility criteria in any given plan document. So the trustees asked that we do a complete dependent audit. We started that in November of last year. There were 3 different participant communications that were sent out, strategically placed within the calendar to try and garner enough information to establish eligibility and substantiation that these dependents that were on the plan were in fact eligible for coverage. The end result of the dependent audit, we removed 66 dependents from the health plan. On average, the number that we used in the plan savings was $10,850. We used that number, which I believe is very conservative. CMS's number in the year of 2020 was $12,500 roughly. So our number's really low. And using a conservative number, we still had nearly $750,000 in potential savings by removing these ineligible dependents from the plan. And then obviously there was a cost of doing the audit, which was $28,000. So it was worth the time. It was a lot of work, a lot of paper, a lot of communication with dependents and employees, but definitely worth going through the process to make sure that our plan was in compliance with the law and that we didn't have non-eligible dependents that were lingering. There were a variety of reasons as to why people were terminated, and we put those stats in the slide for you. And it's my understanding that you guys all have copies of this or will eventually. So feel free to reach out with any questions that you may have on the dependent audit. I'll also open it up if anybody has any questions before I move on to my next slide. We're good. Okay. The next slide is the I'll wait till Reagan advances it for me. Roe versus Wade. So as you know, on June 24th of this year, the United States Supreme Court issued its decision in Dobbs versus Jackson Women's Health Organization, overturning the long-standing precedent of Roe versus Wade and holding that there's no constitutionally protected right to abortion in the United States. While the Dobbs decision does not make an abortion illegal, it does permit states to make abortion illegal under their state law. So the decision came down and then there was this flurry of activity, which is still ongoing across the country. It goes without saying that the decision and the implications have a very broad impact for the entire healthcare landscape. There are still many complicated legal questions and various state laws that we're weeding through. Some of you may have heard these terms. It was kind of new for me, being a lawyer for over 20 years. There's such a thing called zombie laws, and then there were also trigger laws, which I'm more familiar with. But the zombie laws are the laws that have been on the books for years. And then when Roe versus Wade came along, that law did not get removed from the books. It just remained stagnant while Roe versus Wade was still precedent. I'll give you an example of a zombie law. There's a 172-year-old abortion law in the state of Wisconsin that now has been revived because Roe versus Wade is no longer precedent. The biggest piece of that particular law in Wisconsin is that it makes a felony to have an abortion in the state of Wisconsin. So all of the states currently are dealing with zombie laws and trigger laws. Trigger laws were laws that were drafted and they were ready to pull the trigger as soon as Roe versus Wade was overturned, if that did in fact occur, which it did. So every state's different. It's kind of a mess. The decision itself is going to require that the AHPT plans get amended. The amendment will be very vague because it's going to have to reference applicable law, because in every state that we operate in, the laws are going to be different and they're going to be every changing. So it's going to become a very manual process for the folks at Campton to adjudicate these claims, because at the time of service and then at the time of the submission of the claim, we're going to have to analyze how that claim should be adjudicated to remain in compliance with any given law at any given time. Like for instance, Texas and Louisiana are very strict and have significant penalties and fines. New Mexico is not so much. New Mexico's really doesn't have much going on. Many benefits in a given health plan are impacted. It's not just what many people originally thought, which was, whether or not abortion is a covered or excluded benefit. There are many areas that we're having to take into consideration, such as the travel-related services, not just the abortion services themselves. Pharmaceutical is coming into play here, and reproductive benefits that plans may be offering are coming into play here. So going forward, claims related to any impacted area will require manual intervention to determine the current state of affairs in that given jurisdiction, and then the appropriate manner in which those claims should be adjudicated will be determined at that time. So it's going to continue to change over time. I don't see the end in sight, if you will. I think we're going to have a few years of legal changes and legal challenges across the country with regard to the impact of the Dobbs decision. But that's how it impacts this particular health plan. It will require an amendment, very generic in nature, and the heavy lifting is going to be on the Kempton side when it's time to adjudicate related claims. Anybody have any questions with regard to that? Okay, seeing none. My next topic here is the Oklahoma Patients' Right to Pharmacy Choice Act. So Oklahoma passed this particular act in 2019, and the purpose of the act was to establish minimum and uniform access by patients to all pharmacies, and to provide network adequacy, transparency in the minds of the Department of Insurance in the state of Oklahoma. And it reminds me of Obamacare or the ACA, when there was a phrase, if you like your doctor, you can keep it. I think the purpose of this particular law was, if you like your pharmacy, you can keep it. And originally, when this bill passed, it related to health insurers, and the definition in the state of Oklahoma of a health insurer at that time did not bring us in as a health plan, and so we didn't really do much about this in 2019. And then also it impacts PBMs, prescription benefit managers, and others as well. But when we narrow it down to how it impacts us, at the time in 2019, it was impacting health insurers and PBMs primarily. The National Trade Association for PBMs is called the Pharmacy Care Management Association. When this act came about, they started challenging the act legally. In 2020, it went before a district court, and the majority of the analysis before the court was whether or not it was going to satisfy the ERISA preemption requirements. There's a longstanding law in this country since the early 70s that a state law cannot preempt ERISA, and that ERISA will trump any state law that impacts a health plan that's subject to ERISA. So the 2020 court decision was kind of focused on that. It didn't pan out very well for the Pharmacy Care Management Association. And then in 2020, the act was amended, and it was amended to include health insurer payers. So now we have health insurers, which we could argue we don't fit into that bucket, and we have health insurer payers, which we probably can't argue that we don't fit into that bucket, because in that bucket, it encompasses any entity providing or administering a self-funded health benefit plan. So all of a sudden in 2020, now we're pulled into this act and the ramifications of the act. The act as amended still applies to PBMs within Oklahoma, and which is the PBM being utilized by the AHPT trust. So we went through some slides earlier with all of the S's, the Southern scripts and script sourcing, and the PBM in our plans is significantly impacted by this act, as are we, but we don't have a license that they're threatening. They are threatening our PBM's license at this point. What the act does to the PBM, and therefore to us, is it does not allow for the mandatory requirement that people use the programs that these PBMs are selling. So there's variable copay programs that are out there across the country. There's the programs where we're doing international sourcing. Anything that the PBMs have created to help the plans save money, they're trying to now take away from us. And so it's still being challenged. The Pharmacy Care Management Association has appealed the district court's decision. The matter is fully briefed at this moment, and it is before the court. I spoke with counsel for the Pharmacy Care Management Association last week just to see if we had any ruling yet, and we still have no decision. Jay and myself and some folks at Southern Scripts have a call next week, actually tomorrow. Tomorrow's Thursday. We have a call tomorrow with the Department of Insurance in the state of Oklahoma to discuss this matter further. My guess is they will have little to say. It will need to continue to be challenged legally, but they clearly don't understand the impact on health plans when I read the case that came out of the district court. So going to try and shed some light on them tomorrow. The attorney that we're dealing with is on the PBM side of the Department of Insurance, and I can guarantee you she doesn't even know what a MIWA is. So it'll be a heavy lift on education, and we'll see if they have any tolerance to be educated. But this is significant, and it's not only significant in Oklahoma. We're seeing these pop up in other states across the country. And my position is that they continue to chip away at self-funding and ERISA to the point that we don't want them to. And so I'm addressing this issue with all of our national associations that help self-funded health plans move initiatives forward. We tried to get to the point where we could file an amicus brief in this case, and it was time barred, but we're going to try and insert ourselves in other cases across the country to try and make an impact. So those are the updates from Trust Council, and I'm happy to entertain any questions you have.
I don't think there are any questions, Corey.
Okay, great.
I might add that at least for this is only an Oklahoma issue for now, but we did attend a briefing probably 3 weeks ago from McAfee Taft law firm here in Oklahoma City, and they are kind of red hot over this as well. This is definitely on their radar and all of their clients. And for anybody that knows Brandon Long over at McAfee, they were doing a webinar, and he was saying that the state of Oklahoma says that this is not a benefit mandate, and so therefore it is fair game that the Oklahoma Insurance Department can do this, because the Oklahoma Department's position is if it was a benefit mandate, it would be preempted by ERISA and not allowed. And I remember during the webinar, I thought it was great. Brandon Long held up a stapled bunch of paper in his hand because this is our plan document for McAfee Taft. We're self-funded. This is our plan document. And there is 6 pages in here that I'm going to have to amend or rip out to comply with this law. So for the Oklahoma Insurance Department to say that this is not a benefit mandate and it won't directly affect ERISA plans, as an employer, they're saying they're wrong. So they're pretty jazzed about this as well. And so this is really more of a stay tuned type of approach. We'll stay on it. We may end up, the trustees were all briefed on this at their trustees meeting last Friday. And they were very jazzed about it as well. And they are, those bankers, those 7 bankers are going to be getting in touch with some of their representatives and some of their contacts in their communities, and are going to start having conversations. If we need the help of the Oklahoma bankers in the audience that are other members, we'll certainly provide some communications in that regard. So I guess we're finished with Corey. Oh, well, that was long gone now. Yeah, okay. Well, yeah, thank you. It came back to me. So on the dependent audit, I was going to kind of close the loop. Corey had talked about, obviously it's not permissible to have people on your plan that are not eligible under your plan. But I would like to remind you, I think we talked about this last year, there's a real exposure issue for Advantage Health Plans and any health plan when you have participants on the plan that are not eligible. And we've talked a little bit more about stop loss this meeting than we have in the past. But if we ended up having somebody that had a $3.9 million claim, well, we're expecting that Advantage Health Plan's responsibility is $275,000, and the rest is paid by the reinsurance company. Well, if they're on the hook for well over $1 million, they're going to ask questions before they just write a check. And some of those questions are going to come to us, and then ultimately we'll go to the bank, and it's going to go like this. Prove to us that this dependent is actually eligible for benefits under the terms of the plan. In other words, they're looking to get out of the claim. And if we're not able to provide documentation illustrating that, yep, that dependent meets all of the eligibility requirements, then the reinsurance carrier could say they're not an eligible member, they're not a proper eligible member under the plan, so we're not going to reimburse. So that $3.9 million claim comes out of the trust fund with no backstop reinsurance. That is a risk that we just can't have. And so this is certainly not about, I don't want anybody to conclude this is about kicking people off the plan. It's about just making sure that we have the people that are on the plan that actually are eligible to be on it. And of course, if somebody, if their eligibility changes and they become eligible, we certainly welcome them onto the plan. But that, I just want to give you all a little bit of the backstory there. It's not just about cost containment, it's more about risk mitigation as well.
Okay, so we're right at 4 o'clock, and I think that is our stopping time. Or was it 5? I'm just kidding.
Listen, if we keep going the next 10 minutes, it'll be a bellwether day.
Well, since the last 4 slides are mine, I will wrap with this. Let's see, a couple of months ago, we sent out another update, another email to everybody on Advantage Health Plans that we had a contact change. So it's not a surprise to everybody that's been around the last couple of years that filling the sales role that requires quite a bit of travel, and we think that it deserves a lot of travel, has been a challenge, and also keeping somebody in that role and having them to do the travel has been a challenge. And so I wanted to just give you a quick update. There is somebody within our organization that has been very stable In fact, she's been with our organization since 1976 and would kill us for saying this out loud. But we have such an amount of respect and admiration for her and what she brings to our team. And anytime that there has been a change with Advantage Health Plans, behind the scenes, she's always played this role, but it hasn't been quite as visible to the bankers and financial institutions on Advantage Health Plans as it has been in some other areas of our organization. So Shannon Kerr is our Vice President of Client Success at the Kempton Company, and she's going to be taking a more active role over the next several months and into the next couple of years on Advantage Health Plans and all things account management related, as Jay and I continue to look a little bit more strategically about what that role entails from a sales perspective and from a calling on the banks and being out in the financial institutions entails. So Shannon is available. Her contact information has been circulated several times in the past. We will do that after this meeting as well, but wanted to make sure that you all knew that even though it might look like there was a little bit of instability occurring, that there has been a lot of stability that's happened behind the scenes, and we want to make sure that you also have access to her expertise that she brings to the table as well.
Yeah, so Shannon has paid for some of the banks that have been with Advanced Health Plans for decades and decades. If you notice, Shannon's hire date predates Advanced Health Plans by 1 year, and she has done really everything for Advanced Health Plans at one point or the other. She was one of the first claims processors that back in the days when we would actually type out checks and work files on paper. She has really done it all, and so as she's at this point in her career, she's going to kind of end where she started. And so we really think that it's going to be a good thing for the bankers. And I think that you all as HR and decision makers, along with your employees, will find Shannon's expertise really invaluable. This does not change the pod structure or anything else. If somebody needs a KPP, they don't need to talk to Shannon. They can talk to the AHP pod through the normal channels. But for those escalated issues that HR sometimes needs help with, the things that you would normally talk to your rep for that would come around to your bank, Shannon would really be your point person for those kind of somewhat escalated issues. And for those of y'all that have done when you had to endure me as your rep back in the day, many of those escalated issues, I would come back to the office and I would ask Shannon to help me with those. So she's been the brains behind a lot that we've done for a long time. So we're happy to have her in this new position.
Yeah, agree. And Shannon, too, will be working with George Kempton, who I introduced to you at the beginning of this meeting. She'll be doing some mentoring with him and helping him to integrate into understanding what the expectations of the bankers are as it relates to education and how we provide information to your teams, to your employees. But one of the, or maybe I should say a couple of the things that we really are putting some focus on. One of those things I announced actually last year, which had to do with the improvements in our customer service call center and the scripting that we were working on with the teams to make sure that information was consistent and effective and robust. George has actually been helping with some additional scripting that we'll be deploying later. Hopefully, the timeline is debatable, but we'll be deploying it later in the next month or so. That gives us a little bit of leeway there, but he's been involved in that and helping to improve some of that scripting in the call center. We're also working on some additional educational videos, and so one of the things that we know is changing is that the dynamic of being able to consume information, it just, that timeline just gets shorter and shorter and shorter. Attention spans are shorter and shorter and shorter. Bankers and employees have less amount of time to be able to dedicate to education. And so we are dedicated to trying to evolve the messaging, make it as simple as it can be while not diluting the message that we all agree is very important. And so we're working on some educational videos that will be broken up into bite-sized, more consumable, shorter modules that we'll be able to provide to the banks and be able to use those for educational opportunities for your employees. We're also ramping up our efforts on social media. And so, I mean, you just basically can't interact with any company, any product, any services now without looking at, TikTok or Facebook or Instagram or Twitter. And that has not been a platform that we've put much effort into in prior years. But one thing that we know is that although we have an opportunity to interact with your employees during educational meetings and emails that we send out and things like that, because they're captive audiences in their place of business, which is where you have them for, 8 to 10 hours a day. We don't have that same opportunity with spouses and dependents. And so one thing that we are learning very quickly is that we have another avenue to be able to spread the message even further, make it a little more effective for the rest of the participants that are on Advantage Health plans that might not be in your organization. And social media is a great way to do that. So over the last several months, George has been procuring content and posting that and reaching out and connecting to as many individuals as we can. We're pushing out messages through email and hopefully letting you all know that that is available. So our hope is that you can encourage your employees to also pass that message along to their spouses and even their kiddos, so that we can bring the message where the people are, which, whether we like it or not, is on social media. So that is definitely an improvement and enhancement that we are making and putting some more effort there. And the last thing that we want to go over is just the open enrollment timeline. From this meeting through the rest of the year, there's a lot of milestones that we have to hit to be able to make it to January 1st. So after this meeting, our hope is that each individual bank that participates in Advantage Health plans will actually have access to your own renewal in hand. We hope to be getting those out during the first week of October. And then, as you know, the definition or the defined period of time in the plan whenever employees are able to make plan design changes and enrollment changes starts October 15th. And so we usually get the renewal out in a couple of different ways. Not only do we mail hard copies to you, but we also place those on your employer portal. So we hope to do that in the first week of October, and then we'll open up open enrollment. If you are making a plan design change, and so if after receiving your renewal and looking at the options that are going to be provided in the renewal packet, you decide that you do want to make a plan design change, we need to know about those, because we'll need to configure our system so that you can go in and make those elections and those changes to the actual employee enrollments. So we do have a deadline of hearing about those plan changes by November the 1st. And then we will continue through the open enrollment period, having your employees make their elections and you turning those into us. We're going to need to get some additional paperwork if you are making a change. So that's the administrative part of that. We'll communicate all these deadlines, but our hope is that we can have that paperwork back in our office and completed by November the 15th. And then on December 1st, open enrollment would close, which that's really the date that you need to know about, because we've got to have all of your employee changes in our office by December 1st so that we can make those changes in our system, get updated ID cards out to you, get those updated ID cards out to your individual employees, and so that they can make sure that they can have those so that there's not any disruption in the claims or the prescriptions that they would be filing after the first of the year. And then obviously January 1st is sort of our end all be all. Everything that we are doing from now until the end of the year leads up to that date. And that's when all of the new things that we talked about today would be effective. And then I always like to leave you with the call of action, which is just some key points that you can take away from this meeting with things that you need to do or that we will be doing in conjunction with you to help you through this renewal. In addition to sending out the renewal either on the portal or in mail, we will contact you. We usually like to give you a heads up, because as soon as this meeting is over, we usually start getting questions about it's 6.5 for the trust, but what's mine? What's my renewal increase? And so our hope is that we can contact you to give you a heads up about what those things are. If you have questions, of course, reach out to us and we're happy to walk through that with you. We would encourage you to schedule some employee education meetings between now and the end of the year. Make sure that that if you have not given us an updated file with your employee email addresses and mobile phone numbers in the last year or so, that you do that. Some of you are very diligent about making sure that happens as changes occur throughout the year, which is great. But we like to use this as an opportunity to just refresh all of our databases, because any communications that we are pushing out, if we have bad information, we miss opportunities to connect with your employees. So if you can provide us another file, we can update all of our systems and make sure that those contact methods are accurate. Start having conversations with your benefits committee on ways that you can adopt a culture of consumerism within your organization. We can give you ideas about that. We can share with you ideas that other employers have done. But since we don't always keep this topic front of mind, we like to remind you that during this time of year, at a minimum, have conversations about what you can do next year. Some banks might put together a newsletter that they send out on a monthly basis. You might be hosting an all-staff employee meeting that you do monthly or on some other frequency, and you could add this topic of conversation to your agenda so you're talking about it more frequently. Some organizations have leave policies that are more favorable to accommodate some of the travel that might occur when a participant is redirecting to a provider through the KPP free program. So that's just a couple of ideas. We can talk to you about more, but I would say in addition to just talking about what plan design you're going to use for the new year, making sure that you get enrollment in, looking at your renewal, add this topic of conversation and strategize with your benefits committee about ways that you can adopt that culture and infiltrate that culture more so in your organization. Any educational materials that we send out, they're publicly posted on our website as well as in our portals, but make sure and share that information with your employees so they get the benefit of being educated about their health plan. And then finally, to promote and encourage the use of the KPP free program and other enhanced benefits of the plan.
Pretty much concludes today's presentation. That was a lot. That's a lot of slides. That breaks every presentation rule ever with 70 some odd slides, but we appreciate you all hanging in there. I think we covered the information quickly, as quickly as possible. Hope this was valuable to you all. Like we had mentioned, next year will be quite a bit easier because we will be 100% remote. So there won't be the challenge of remoting people in to a local audience and a remote audience and all that. It's just kind of a sign of the times. I think it's what the bankers are looking for. So that's what we'll be doing. We'll be doing this remote, but we do look forward to seeing you all every single year. So hopefully there'll be other opportunities. We'll see you all at conventions and et cetera, and probably also at the bank a few times. So, okay. Thank you all very much.